Hi, I'm Dr. Arlene Chapman, Professor of Medicine, Chief of Nephrology, and Director of the Clinical Research Center at the University of Chicago. I'm also a work group member of the KDIGO 2025 Clinical Practice Guideline for the evaluation, management, and treatment of autosomal dominant polycystic kidney disease. In this video, I'd like to share some key takeaways that we've highlighted for the management of chronic kidney disease, or CKD, in ADPKD. First, we're going to look at some insights and takeaways pertaining to CKD management. Management of the complications of CKD and lipid-lowering therapy for the primary prevention of cardiovascular disease in people with ADPKD should be similar to those with other kidney disorders. HIF-PHIs should not be used to manage anemia in people with ADPKD who are not receiving dialysis, as they theoretically exacerbate cystogenesis. Diabetes management should be the same as the general population. However, it should be noted that SGLT2 inhibitors and GLP-1 receptor agonists are not recommended until more data is available in patients with ADPKD. Our next key takeaway highlights native nephrectomy. Native nephrectomy should only be performed for specific indications, usually in people with ADPKD receiving a kidney transplant. We've illustrated some of the indications here in this figure. Native nephrectomy should be considered by a multidisciplinary team in a center with sufficient surgical experience and only in cases where the benefit outweighs the risk. Ideally, native nephrectomy should not precede need for kidney replacement therapy and should be unilateral whenever appropriate. Next, we'll highlight some key points concerning transplantation. Living-related donor transplantation done preemptively is the optimal treatment for kidney failure in people with ADPKD. Several complications after kidney transplant are more common in ADPKD individuals. We highlighted those complications in this figure. Due to the reduced availability of living-related donors in ADPKD families, there is value in evaluating the extended family, the wider circle of friends, co-workers, and acquaintances. Potential at-risk blood-related donors should undergo thorough evaluation to exclude the presence of ADPKD. Next, we turn our attention to assessment of weight and body mass index. The transplant team should take into consideration the increased weight or volume of enlarged cystic organs. And what this means is that during the health screening phase before kidney transplantation, the body weight should be adjusted for the estimated polycystic kidney and liver weights to arrive at a more accurate indication of the patient's body mass index. This can be done using the equation shown. Now let's take a look at some important insights about dialysis. Peritoneal and hemodialysis are both acceptable modalities for people with ADPKD, with comparable long-term outcomes in mortality. However, people at high risk of abdominal hernias should be counseled to consider avoiding peritoneal dialysis. The guideline also states that there are no objective criteria for total kidney volume that would predict either success or failure of peritoneal dialysis. And finally, for this area of focus, clinical trials. We want to reinforce to clinicians the notion that voluntary participation in clinical trials of intervention to slow progression of ADPKD should be offered to all eligible people with ADPKD. That concludes our focus on management of CKD and ADPKD. Thanks for watching. I also encourage you to take the time to explore the entire collection of videos we've assembled on this guideline. We're all very proud of this work, and we hope it will meaningfully support both clinicians and the people we care for around the world. The full clinical practice guideline can be accessed online at www.kdigo.org.